5 years ago, Medicare spent about $15 million on remote patient monitoring. Last year, that number exceeded $530 million. To put that in perspective, Medicare spends more than $1 trillion every year. So remote patient monitoring is still a tiny fraction of that total spend. So why is CMS proposing one of the most significant changes to the industry that it's seen? So why is there so much focus and discussion about a program that accounts for less than 5 cents per $100 spent? It's not because of the dollars, it's because of the direction. This is the wave of the future, and healthcare and CMS believes that. I believe that. I'm Scott Hozebin, CEO of DirectCareAI, and I've spent the last 20 years working in remote monitoring and diagnostics. Over the past few days, I've been reading through the proposed 2027 Medicare Physician Fee Schedule, and most conversations are about which billing codes changed. The bigger question is this: what are the clear signposts that CMS are putting up? When I step back and look at the proposal as a whole, I see one consistent message. CMS wants healthcare to become more accountable, more integrated, and more focused on caring for patients in between the office visits. Let me explain why I believe that. The first signal is physician payment. Overall, Medicare is proposing a modest reduction in physician reimbursement. Not the best. Many headlines are calling this another payment cut, but the story is a little more nuanced. Every Medicare service has a value assigned to it. That value is multiplied by a dollar amount called the conversion factor to determine what Medicare pays. For 2027, CMS is proposing a slight lower conversion factor. Much of that reduction isn't because CMS created a new cut, it's because Congress provided a temporary 2.5% payments increase for 2026, and that increase is scheduled to expire at the end of the year, unless Congress acts again. The reductions being discussed are roughly 1% to 2%. That may not sound significant, but when physician practices are already dealing with higher wages, higher technology costs, higher malpractice premiums, and growing administrative requirements, even a 1 or 2% change makes a big difference. The second signal is much more interesting. CMS is proposing to significantly increase payments for physicians who are providing ongoing longitudinal care. The current G-code 2211 as an add-on would become a percentage increase tied to the office visit itself, with even larger increase proposed for qualifying physicians that participate in an accountable care organization. Whether you agree with every aspect of the policy or not, the message is clear. CMS wants to reward long-term relationships between physicians and patients. Now, let's talk about the proposed changes to remote patient monitoring that are receiving the most attention and really affect a lot of what's in my world and all of those that are into telehealth, remote patient monitoring, chronic care management. Today, many physician practices partner with specialized organizations to deliver these programs. The physician remains responsible for the patient's care, but an outside organization often provides the nurses, medical assistants, patient outreach, technology platforms, documentation support, and device logistics that make these programs work at scale. CMS is proposing a significant change. Under their proposal, Medicare would only pay for remote patient monitoring and remote therapeutic monitoring services when the clinical staff performing those services are employed by the billing practice rather than working as a contracted staff or outsourced support. That's a fundamental change in how much of this industry currently operates. Ironically, we've seen the issue before. When these codes were originally introduced, CMS took a much more restrictive approach to staffing as well. But then after hearing from physicians and industry stakeholders that the model wasn't practical, CMS revised the policy and allowed contracted and leased clinical staff under appropriate supervision. So it's a substantial amount of technical and operational lift to accomplish these programs. This proposal would move back in the opposite direction. So it's a bit of Groundhog Day feeling, but it goes to show a persistent appetite for a direction, even after hearing from the stakeholders previously. That raises an important question. Can smaller physician practices realistically hire, train, supervise, and retain their own remote clinical teams while also building the technology, documentation, compliance, and patient engagement infrastructure that's required to operate these programs effectively? Maybe some can, many cannot. That's why I believe the public comment period right now is going to be so important. The goal should be preserving accountability without reducing patient access. There's another proposal that deserves attention as well. CMS believes remote monitoring devices have become less expensive and is proposing to change the amount that would be reimbursed tied to services. Hardware prices haven't dramatically changed over time, and the device itself is only a small part of that equation. Most devices run, say, $60 to $80, but some others can be much more expensive. But then there is cellular connectivity, shipping, replacement inventory, patient onboarding, technical support, clinical documentation, monitoring, escalation, and perhaps the largest variable of all, patient engagement. Medicare generally requires at least 2 days of transmitted data during a 30-day period before monitoring services can be billed. This is a big leap forward from the 16 needed before, and it helps a lot. But patients who don't reach that threshold of 2 still require outreach and support that may generate no reimbursement for that month. So looking only at the cost of the billable hardware doesn't fully reflect the operational cost of delivering successful remote care. One point I want to clarify, because I've already seen a lot of confusion online with this whole thing, is that the proposed employment requirement applies specifically so far and explicitly states remote patient monitoring and remote therapeutic monitoring. It has not explicitly mentioned applying chronic care management codes. So that distinction is important because organizations may begin to separate out remote monitoring workflows from broader chronic care coordination if this proposal is finalized. Now, if you step back from the individual policies, something interesting starts to emerge to me, and I imagine likely you. Higher payment for longitudinal care, greater incentives for accountable care organizations, shared medical appointments, expanded diabetes education, medical nutrition therapy, questions about restructuring how remote monitoring and chronic care management integrates together, technology integrated into primary care. These aren't isolated policy decisions. They're all pointing in the same direction. CMS appears to be rewarding continuous relationships with patients instead of isolated encounters. That's the story I think healthcare leaders should be paying attention to. For us at DirectCareAI, this doesn't change our strategy, it reinforces it. We've been investing in longitudinal care, chronic disease management, interoperability, AI, physician enablement, and technology that supports care in between the office visits. Whether this proposal changes before becoming final or not, I believe that is where healthcare is headed. The organizations that spend the next year just optimizing for individual billing codes might improve the next quarter's revenue, but the organizations that build integrated, accountable, technology-enabled chronic care platforms will shape the next decade of healthcare. That's the conversation I believe this proposed rule is really asking us to have.